All right, good morning. Hello, hello. My name is Eric Schnadig. I want to begin by offering a very warm welcome to all of you here in St. Louis and virtually. It's great to be here. Who would have believed that it would have been 3 years since we last did this? And it's great to finally be back together. The original plan was to meet here in the fall of 2020. And then, of course, the world turned upside down, COVID. And I'm really pleased that we're turning the page together today. Thanks to the wonderful people of St. Louis Children's Hospital, to Dr. Baddr Shakhsheer, our sponsor and co-host, to all the speakers, organizers, administrators. Thanks so much. And then, of course, thanks to the REACH team for making this event happen. It's great to see you all in person again. It's been 3 years for all of us too. And we've really become an extended family. Every year we do bigger and better things. And I look forward to that continuing journey. Thanks to the families here and virtually. I hope we'll see a few more come in here through the course of the morning. We're very much bonded by this disease, and you too are part of the REACH extended family. REACH began like many startups in a friend's living room. It was my wife Isabel's idea. In 2006, our son Adrian was born with total colonic Hirschsprungs. And when Adrian came into our family, things got pretty crazy. We had wonderful doctors and surgeons, but we lacked a community. And so Isabel asked the question, hey, why don't we do something about it? Not long after, with the help of Dr. Alan Goldstein, we got connected with Liz Crawford, who'd been working in parallel on the same idea, problem in Canada. And voila, REACH was born with a founding team and a mission. REACH stands for Research, Education, and Awareness for Children with Hirschsprungs. I think the acronym does a nice job of describing our mission. We're not-for-profit, and we're essentially powered by volunteer parents, doctors, and researchers. And our aim is to serve the HD community worldwide. Speaking of doctors and researchers, I want to recognize in particular Doctors Alan Goldstein and Jack Langer, who you'll meet and hear from today. Not only are they gifted surgeons and scientists, they're wonderful human beings. We're blessed to have them as a part of REACH. Thank you. So REACH's mission it's threefold. First, we want to create a one-stop shop for community of families and patients like us. We want to act as a bridge between these families and the medical and research community. And three, we want to fund research and innovation in the field. In terms of resources for families, we do a lot of practical things, including events such as these in person now, hopefully again, and virtual. I think equally important is the role REACH plays in providing community and emotional support. This takes many forms. Most recently, we published a book called My Little Brother Has Hirschsprung Disease. And I think that's an example of the kind of emotional support we can offer. And of course, we fund research. In fact, we've been funding grants since 2013, doing our small part in advancing this field. We're currently undertaking two significant new initiatives. First, an HD mobile application designed to be a simple way to record and track our kids' daily health and diet and and poop for easy sharing with caregivers and researchers. We hope users of the app will opt in to our second initiative, which is a patient registry. So why is a registry important? Because I can see a day, I think this may be the first time I can say this, I can see a day in the not too distant future when new treatments will become available. For example, in the realm of innovative stem cell therapies. And researchers and drug companies, they need easier access to patients to explore, among other things, willingness to enroll in clinical trials. So stay tuned for more on that and other exciting new projects. But this group here and virtually is our ultimate constituency. So if there are other initiatives that you think we should undertake for the community, tell me, tell us. We're here to serve the needs of our families. In the meantime, welcome again. I'm sure you're looking forward to a day of learning and connections. And let me turn it over to Dr. Shakhsheer. Thank you.
Good morning. I'm just opening up the chat window. So those of you who are virtual and who want to participate, you're welcome to send chats and I will awkwardly message you back. I feel like I've been practicing to be able to text during everything I do for all my life. So now I get to utilize the skill. My name is Baddr Shakhsheer. I'm one of the pediatric surgeons here at St. Louis Children's and Washington University. I'm here to just give an introduction on Hirschsprung disease. In a lot of you in the room here and virtually could probably give this lecture better than I can when it comes to what the outcomes are like, especially what we talk about at the end of this talk. But hopefully it will set the frame for kind of the rest of the day. So I have no disclosures. All right, so we're gonna ask today who, what, where, when, why, how, the classic questions. And so we'll talk about Hirschsprung disease, named after Harold Hirschsprung here, pictured on the right. All right, so what is Hirschsprung disease? There are so many names for this disease. It's called aganglionic megacolon, congenital megacolon, congenital intestinal aganglionosis. And so to break down these words, congenital means that this is a genetic disorder. This is something you're born with. Aganglionic means that there's no nerves. And so when the pathologists look at either biopsies or the colon under the microscope, they will see stains such as what you see on the screen. And what they look for is no ganglion cells or no nerve cells and hypertrophied nerve fibers or fibers that are too thick, trying to compensate for the problem. And then megacolon, that one's pretty obvious, really large colon, and I'll show a picture here of where that comes from. So what causes Hirschsprung disease? So when we are in our mother's belly, the normal development occurs when neural crest cells, which are these kind of precursor or progenitor cells, migrate down the colon. So they travel from the first part of the GI tract all the way to the end of the GI tract. And that's what helps the driving nerve cells for your colon to work and squeeze. And in Hirschsprung disease, the neural crest cells either don't complete this migration or there's something that stops it. And so the affected segment, which is always towards the end, it causes a functional obstruction. So it's not a true blockage, but it just doesn't work. Interestingly, because the segment before it gets dilated for many, many years in the past, people thought that this dilated segment was the problem. And so they would remove the dilated segment, which obviously caused more problems than benefits. So part of the early workup is usually imaging. And what we can see imaging here, here's an X-ray of a neonate. And what you see here, you can get the picture that the belly is distended or bloated, right? You can see it looks like the lungs are squished or looks like the kid has had a big meal and hasn't been able to process it yet. And the loops of bowel are dilated, and frequently people will undergo lower GI or enema studies. And what we see on the enema studies is kind of that contracted end part of the colon and then a transition to that big dilated part. And in fact, that transition is what we see in the operating room as well. So here's an intraoperative photo which shows the kind of contracted distal part or end part, and then the part that comes before it dilated, in the same way that you would pinch off a water balloon and get everything to squeeze up beforehand. When we look at where does this transition or this crossover point occur from the nerves to the no nerves, we see the vast majority of Hirschsprung disease is really what we call rectosigmoid. So to orient you, this is the right colon, here's the appendix, there's the small bowel coming in, and the large bowel makes a big question mark before you poop from your anus. And you can see here that 75–80% of the disease is located in the left colon. And really the numbers go down as you kind of get farther along the colon, and then total colonic Hirschsprung's or total colonic aganglionosis is less than 10% of cases. I think it's important to know that this transition isn't a on-off switch, but kind of a relative transition. So this idea of a paint can phenomenon, or the switch over from one part of the colon with nerves to the part without, it's probably not a clear transition all the way around. So you can be somewhere in this crossover zone in the same way that you see it kind of paint fall down the sides of a paint can. We know that Hirschsprung disease doesn't just occur on its own, that there are other diseases. So this is from a paper about 10 years ago looking at other issues that are associated with Hirschsprung's disease. So eye diseases, kidney diseases, heart disease, hearing issues, central nervous system issues, and others. And we know, this is our experience, that Hirschsprung disease doesn't always happen on its own, isolated in a silo. So when is Hirschsprung disease diagnosed? It's diagnosed in the neonatal period most often. Okay, and the symptoms, there can be delayed passage of the meconium or the first stool. The children can be constipated or vomiting, or probably the presentation that we fear most is enterocolitis, or that infected picture with fevers and need for acute treatment of an illness. Approximately 30% is diagnosed after the neonatal period. We're hoping that this number decreases as we increase recognition and increase availability of the tools that we use to diagnose. Nevertheless, we still have patients who present late or outside of the neonatal period. And just to note that the presentation of Hirschsprung disease outside of the developed world can be very different, right? And we all read stories and have seen patients who present with severe failure to thrive, severe distension of the belly. And this is really a much different picture. And in this case, having an ostomy or being able to get diverted and be able to get the stool out, this can be really life-saving. So who gets Hirschsprung's disease? So the estimate is that the disease affects about 1 in 5,000 newborns. It's about a 3 to 4 to 1 ratio of males to females. And we talked about associated disorders, but there are also associated syndromes, of which I put a very small list here. And we're really starting to understand the genetic basis of this disease as we learn more and study more samples, and we're able to drill down on the actual causes. And you can see a table here from one of Dr. Goldstein's papers looking at the genetic basis, 12 different genes identified there. So how do we diagnose Hirschsprung disease? Well, there are a couple of different options. So probably the most common, especially in the neonatal period, is what's called a suction rectal biopsy. So you use this gun device and insert it transanally and take a piece, and the pathologist looks at it under the microscope. And they look for a couple of different things. They look for a lack of the ganglion cells. And we certainly have other stains nowadays that maybe have increased the reliability of our ability to diagnose. For patients presenting later or for other issues, we sometimes do a full thickness rectal biopsy, which is a surgical procedure to take a bigger piece and then close up the hole. And then there's a lot of literature about using anorectal manometry, which I think Dr. Yeager is going to speak about later, so I won't touch base on that, but using that to diagnose. And the treatment, so the treatment comes in a couple of forms, but it's basically to get the good part of the bowel or the bowel that has nerve cells in it to function and get the bad part out. So traditionally, this was done with a leveling colostomy or finding where that transition occurs and bringing that out as an ostomy. And then a pull-through procedure, although in the modern era, we will sometimes go right to the pull-through procedure without the leveling ostomy beforehand. The pull-through procedure removes the segment without the nerve cell and then sews together the bowel with the nerve cell down to the anorectal junction. Pull-through procedures come in a couple of different varieties. I won't go through this in detail, but I like this diagram from this paper. So this is a cross-section of the lower GI tract. So what you see here is the sphincter muscles and the anorectal junction where stool exits. And there's really three procedures that predominate. There's the Suave-Yancey procedure, where you can see the bowel with nerve cells is brought inside of a muscular cuff of the bowel without nerve cells, and then is sewn here close to the bottom above the sphincter muscles. There's the Swenson, which is a very similar procedure, bringing it down, but without the muscular cuff and sewing together the synastomosis. And the Duhamel procedure, where the rectum is left intact without its nerve cells, and the innervated bowel or the bowel with nerve cells is brought behind and sewn together. I think probably more important that, there's a question in the chat, is there a procedure that creates less scar tissue in the future? It's a great question. When you look at these three procedures and you look at just general outcomes, no one has ever really proven the superiority of one of these procedures over the other. But in terms of scar tissue, I think probably the more modern approaches with laparoscopy or minimally invasive surgery instead of open surgery, and if possible, skipping the ostomy, can decrease less abdominal scar tissue, although that's not necessarily related to functional outcomes yet. Okay. So still an area where treatment is evolving and hopefully patient outcomes are improving. Because really, this is where the money is. This is where you all should be lecturing us. And so this is from a paper in 2012, and it's a very busy slide, but I think it's easy to summarize here when you look at this number they derive, this optimal outcome score. I don't think any of us in the room feel comfortable with optimal outcome scores in the 50%. And the reality is you can measure this any way you want. It's not as good as we want it to be, and there's room for improvement. And this is maybe the next frontier of Hirschsprung disease, is to make sure that not only can we treat the disease up front, but can we really improve the quality of life for our patients? Because when you look at these busy slides and you look at patients with Hirschsprung disease compared to controls, and we look at feeling the urge to defecate, the ability to hold back when you want to, soiling, accidents, constipation, social problems, and then try to come up with a whole score, we all know that it's not where it needs to be. We were talking a little bit about this last night, but when you break down these scores and you look at them in age groups, it's very clear that younger patients may have a little more trouble, and this is now comparing the patients with Hirschsprung disease in blue to the outcomes of control patients in red, that maybe when they get to the older ages, the differences aren't as pronounced. And perhaps this is a sign that either the patients get better at managing their own disease, or there's a future there for the patients who are kind of in this younger group, that something to look forward to, some improved quality of life. I think it's also good to remember that Hirschsprung's is relatively young within its evolution. You know, our first description by Dr. Hirschsprung was in the late 1800s, so we're still only 150 years into this. And when you look at the advents and how long it's really taken some of these, what we consider tenets of care, to become ingrained in medical practice, hopefully our learning curve is now on the exponential portion, that we're going to get better faster. I'm going to stop right there and see if there's any questions. And if not, I'll be happy to introduce Dr. Langer to give his talk. All right, great.